Welcome. We'll begin soon. Sahar, I congratulate you on the award. We'll begin here in just a minute. I hope you're well today. I apologize for not putting the slides out and making them available to you in advance, but you will be able to review them afterwards. I have created a link to allow you to access them after we're finished today. So you can come back and study these at your leisure after the program is over. Well, welcome. I'm going to go ahead and start now. We appreciate you taking the time to be with us today. And I have prepared about 8 or 10 cases that I think will be instructive, trying a little bit of a new area today. So I'm going to start with the, let's see if we can just get this out of the way here. With a case that I think is quite illustrative, and it comes from an area of pathology I'm obviously very interested in. This was a 23-year-old woman who had an ovarian mass. And of course, as routinely evaluated in a young person, they did hormone markers and other tumor markers before surgery and did not detect any specific findings there. And so, of course, a frozen section was performed, and that's why this slide is of a little lower quality. As we can see at low power, it has nests and cords of blue cells with intervening areas of either necrosis or hemorrhage and a little bit of ovarian parenchyma surrounding it. It did not appear to be involving the surface. It's mostly solid. And so we'll come in on higher magnification and let you see a little bit more about the nature of these cells. We don't see any specific architecture in this location. We do see some sort of separation, loosely cohesive cells. And here, as we come in at higher magnification, I think you'll see that there's a modest degree of pleomorphism, fairly abundant cytoplasm. These cells are not right back to back. And the cytoplasm is a little bit purplish. The intervening areas, here we can see some necrosis here and over here. Not a lot of inflammatory cells in this lesion. So I think the differential here is very important because that's going to govern further management, both intraoperatively and then, of course, as we begin to work up the case a little bit beyond that. So I think the differential in this situation really resides in a young woman between a germ cell tumor, probably dysgerminoma, maybe yolk sac tumor, and some sort of a sex-scored stromal tumor or something of that sort, a juvenile granulosa cell tumor or a high-grade Sertoli tumor would be considered in the differential diagnosis. It does not look like a common epithelial carcinoma. It's obviously not a borderline tumor, which can also occur in this age group. So by providing the surgeon with that kind of a differential, that helps them to guide further therapy and management intraoperatively. Because of the possibility of germ cell tumor, peritoneal staging and sampling to exclude occult disease was important. So we'll go to the next slide, which is the permanent section for this slide. And I think we see reiterated here the features that we've seen before with maybe a little bit better histologic appearance. We'll come in on higher magnification and scout around a little bit. And the features are fairly similar to what we saw in frozen section without the frozen artifact. We do begin to see here a few areas where there may be some lymphocytes intervening in the stroma, but essentially no new findings on this slide. So we'll go to a better section of this tumor, which I think will show us a little bit more of the features that we'd like to use in classification. So one of the things is that we don't see the large cystic follicles that you might see with a juvenile granulosa cell tumor. Even though these cells have abundant cytoplasm, they really are not great follicular structures. This is maybe about as close as you come to a follicle-like structure, and it's really probably a blood vessel. We do see a few more lymphocytes here, and we're not seeing any other features. We're not seeing the lace-like pattern of a yolk sac tumor. We're not seeing other markers to suggest that. And so since the lymphocytes here are fairly sparse, we do want to consider the possibility of other germ cell neoplasms besides dysgerminoma. So we did a panel of immunohistochemical stains in this case, which showed that, as expected, these cells were negative for sex-scored stromal markers like MART1 and inhibin. There was a little bit of cytokeratin expression, which would be a little bit unusual for dysgerminoma, but there was some expression. But the cells were nicely positive with PLAP, with OCT3/4, with SAL4, and they did not express CD117. Excuse me, no. They were positive with CD117, but they were negative with AFP and with CD30, which we would expect if it was a embryonal carcinoma. So our final diagnosis in this case was dysgerminoma. There were a few scattered HCG positive cells, but that does not preclude that diagnosis, but does indicate that potentially that might be slightly elevated as a tumor marker in this case. So final diagnosis then on this case was or is a dysgerminoma. It was localized to the ovary, so it's a stage one case. There was a little bit of roughening of the surface, so I think it was a 1C because of possible partial rupture. So I'll pause for a moment to see if anyone has any questions. You can certainly unmute yourself and pipe in with a question if you have a question that you would like to ask about this case. If you think of something later, feel free to type it into the chat box, and we will take a minute at the end of the presentation and try to cover those questions. So let's go on to another case. This is an endometrial curettage. It's not a particularly hard diagnostic problem. As we can see, there's lots of blue tissue here, some of it forming glandular structures, some a little bit more solid. There is some spacing between the glands, but you can see here that the epithelium is quite crowded, a little bit irregular in terms of shape of the glands, and the nuclei are fairly palisaded. In other areas, such as here, we have a little bit dirtier appearance, a little more rounding up of the nuclei, a higher grade nuclei, some solid pattern growth, and a lot of inflammation along with this. So in an endometrial curettage, this was an older woman, I think in her late 50s. This would certainly fit for an endometrial adenocarcinoma. So not a diagnostic problem per se, but I did think it would be important to just touch on what we do routinely now in the evaluation of these tumors. So while grading is a useful prognostic indicator by and large, there are some instances where we can miss areas of serous differentiation, and that clearly changes the prognosis in these patients. So we routinely do a p53 stain. In our referral practice, we see not infrequently, a few times each year, cases that come in as supposedly low-grade endometrial adenocarcinoma that in fact turn out to be serous carcinoma that just has been overlooked or underappreciated by the initially evaluating pathologist. So consider doing a p53 stain, especially if you're seeing any suggestion of higher grade nuclei. The other feature that we do, and which is, and I think is much more widely practiced than a p53 stain, of course, is mismatch repair protein evaluation. So we use a 4 antibody panel, which includes MLH1 and PMS2, as well as MSH6 and MSH2. And so I've included one of those stains here to illustrate one of the problems to be aware of. So this is, I believe, MLH1. And MLH1 and PMS2 are the most frequently lost markers. But as you evaluate this stain, I would point out to you the fact that we've got what looks like 2 different patterns. So we have here first in this fragment here, you see the pallor. Now with this marker, you have some degree of an internal control. So the stromal cells are positive, but note that all of the tumor cells in this fragment, all the epithelial cells are negative for this marker. And so this represents loss of this mismatch repair protein. And a corresponding feature would be seen on PMS2 because those are a dimer. And if MLH1 is lost, then PMS2 will also be lost. But here in other areas of the tumor, you see that we have the marker is retained. So this is a mismatch repair intact feature. So how should this patient be treated? How should this be reported? Well, I think in many laboratories, the fact that large areas of the tumor, like here and here and here, are retaining the marker, this would be reported as retained. But we don't know for sure if that is going to truly reflect the biology. And so I think if you have clonal areas like this where you have lost expression of one of these mismatch repair proteins, that should be reported as a potential indicator that there's some heterogeneity in the tumor, and that potentially these patients may be candidates for immunomodulatory therapy, because that's the main differential, or the main differentiator here, is if they have lost one of these mismatch repair proteins and they're unstable, most likely this is due to hypermethylation, but they would still potentially, at least in this portion of the tumor, be more responsive to immune modulatory agents, such as pembrolizumab. So I show you that just to reinforce the importance to examine all of the tissue that you've got and report any significant variations in the outcome. Questions or comments about that? Please feel free to speak up if there is one. All right, well, in the next few minutes, I thought we would launch into a somewhat different area of pathology and talk about breast biopsies. I see many of my colleagues here and good friends from Vietnam have joined the class, the talk. And I know you see a fair number of breast biopsies in your practice. So in our world, where I am practicing, typically the patients will have screening mammograms plus or minus ultrasound examination. And most of our exam samples are ultrasound guided biopsies if they've detected an abnormality. And so when they do that, they will usually report, the radiologist, who is often the one doing these biopsies, will report what they call the BI-RADS score. And probably this is an international standard, so many of you probably also see the BI-RADS score. But typically, in order to evaluate or to qualify to get a biopsy, they have to be at least a BI-RADS 4, and that will satisfy the insurance payers that this patient needs to have a biopsy. So here we see a number of small grouped glands with a little bit of papillary complexity. We see some blue areas. This was a BI-RADS 4 case, and then we see this area that they sort of nipped some blue tissue here. So we'll go and look a little higher magnification at this sample, and we can see here that most of this is fairly bland apocrine metaplasia with this nice papillarity and abundant eosinophilic cells, round nuclei, not usually a problem in the diagnosis, but very frequently encountered. Here we have a little bit of hyperplasia, a little bit of sieve-like changes and so forth, but benign ducts and glands there. So we'll go up here to this other area here, and this is the obvious carcinoma, I guess you'd say, based on the coloration. So I've selected a number of cases. Actually, these are all cases that came in on one day. So just to give you an example of one day's breast service. In this situation, we have some solid growth here and here and here, and then this infiltrative pattern of growth. So we have what looks like in situ carcinoma here with this rounded nest here, and maybe a little bit of residual duct there, maybe a little bit more here, and then an infiltrative pattern. Now, in our practice, we use the Nottingham grading system to provide a grade based on architecture, mitotic activity, and nuclear features. So I'm not sure that we'll be able to see really well the nuclear features. There is here a degree of gland formation, rounded nests, and so forth. And I think you can appreciate that the nuclei are relatively round. The third area, mitotic figures, we're probably not going to be able to evaluate well with these 20x scans. So you'll probably have to take my word for it that this case was called a grade 1 on the basis of grade 2 architecture, grade 2 nuclei, and low mitotic index. Now, one of the questions that you might ask was, well, could this be lobular carcinoma? And I think when you see strands and cords like this, that question very justifiably comes to mind, and that should be considered. So while we recognize that this architecture, this Indian file thing pattern suggests lobular carcinoma, we've come to rely a little bit more in terms of discriminating those to use immunohistochemistry. And so in this case, we did an E-cadherin stain. The cells were positive, indicating that they were ductal derived cells. So that's just a little example of what we would see here on one of these cases. Whoops. Well, I don't know why I did that. We'll just go on to the next case. So in contrast, sometimes we get biopsies where there's very minimal abnormality, but the patient has a history of, or a family history that suggests high risk for breast cancer. So this was a BI-RADS4 lesion. It had a very small focus here of abnormality, and most of the tissue is just benign fibrofatty tissue with a few bland ducts. But since this patient had the history of in their family of carcinoma, that also would lead to a lower threshold to biopsy. Now, we also, however, have here this little fragment out here. And as you can see, this is not really attached to the tissue, but it has a papillary pattern of architecture, some sclerosis in between, and these lining epithelial cells around the edges of this fragment. This appearance of a fragment like this sort of floating along with the tissue is a strong suggestion that there's some sort of a intraductal papilloma type of lesion in this patient. We're not seeing the duct per se. This might have been related to it, but again, it's not clear that that's the case. But finding a lesion like this in a sample like this will usually lead our surgeons to perform a local excision to excise the lesion and to evaluate more fully the wall and the areas around it. An area like this, we would probably want to go to a higher magnification to make sure this isn't a focus of infiltrating tumor, but it is have a lobular appearance. If we were concerned, we could do a P63 stain and so forth. Now, we do have a degree of ductal hyperplasia here. We can see the snouting on these cells, and they're sort of piled up a little bit. But this is more characteristic of usual ductal hyperplasia than of atypical hyperplasia. Atypical hyperplasia in our area looks more like ductal carcinoma in situ, but isn't either sufficiently quantitatively enough to qualify for that designation, or is not sufficiently atypical to move it to DCIS. We'll take a look down here, and I think here we can see more of this hyperplasia type of appearance. Note the lobularity here. That's very helpful in excluding malignancy in terms of the variability here. And this also has some of those intraductal papilloma type of features that we saw in that detached fragment. But here you can see in a portion of the wall, again, this sort of hyperplastic appearance of some of the surrounding glandular tissue. So our sign-out diagnosis of this would be descriptive of what we see, detached papillary fragment, suggesting an intraductal papilloma, usual ductal hyperplasia, and potentially intraductal papillomatosis without any evidence of high-grade atypia. Now, if on the sample or the radiography they had noted calcifications, we would want to be sure to identify those. And I'm not sure if that's what we've got here or not. I can't tell for sure from here. But we typically will do 9 step-level sections through the sample, and we will stain with H&E section 1, section 5, and section 9. And that allows us several intervening unstained sections to be able to then use for immunohistochemistry. If we've got cancer in it, or if we need to do to evaluate for potentially invasion or something like that, we can use a P63 on a nearby section without having wasted tissue or lost the diagnostic material. So cutting multiple levels on these breast biopsies, saving intervening levels for possible immunohistochemistry is a good practice to follow in your laboratory. Okay, so the next patient is a patient who has both a mass in the breast, and when they detect something on that type of exam, especially something that looks suspicious, the radiographer will immediately go and use the ultrasound to evaluate the axillary nodes. And if there is something there that looks suspicious, they will, of course, biopsy that as well, thus giving them both diagnostic and staging information to begin with. Many of those patients may then undergo neoadjuvant treatment prior to a definitive surgery, and this is very helpful in that evaluation. So here we see a needle core biopsy, and we have just a little bit of residual lymphoid architecture here. And in this fragment, we can see that we have subcapsular tumor cells, infiltrative tumor cells in areas of the sinusoids. And we can see that this is a fairly solid tumor, probably nuclear grade 2 again. And then we've got broad areas of the node that are essentially totally replaced by the tumor. Now, conventionally, the Nottingham classification scheme is not applied to breast tumors in other sites, for example, in the lymph node. And so it would technically not be appropriate to give this a Nottingham grade on the basis of the usual criteria, because really you've lost the predictive value of the architecture. However, you can suggest a degree of differentiation based on nuclear and mitotic features that probably put this into the moderately differentiated category, given the fact that we have relatively uniform, mildly pleomorphic nuclei. There were quite a few mitoses in here, as you see here in a few areas, and probably solid architecture. But I again emphasize that you do not have to use the Nottingham grade on samples obtained from, lymph node, liver, bone, et cetera, et cetera. It's not, its predictive value is not validated in those sites. So metastatic breast carcinoma involving an axillary lymph node, probably moderately differentiated type of lesion. Now, if at the same time the radiographer had biopsied the breast sample, and then of course we would use the Nottingham grade, and we wouldn't need to classify the grade or grade the axillary node. We would just say metastatic carcinoma consistent with breast origin in that circumstance. Okay, well, let's move on. One more case here in the breast. As you can see here, this is diffusely abnormal in all 4 cores. I'll mention here that one thing that we also do in management, particularly if there's small or we're concerned about scant tissue, is that we will sometimes divide multiple cores into more than one cassette. So that if we anticipate needing to do multiple immunohistochemical stains, or we have maybe a need to do molecular analyses on something, that we've got more than one block that has a tumor in it. So this case I give to you to sort of help practice grading these tumors using the Nottingham scoring system. This is obviously a very sclerosing type of tumor. We see a lot of this desmoplastic spindle-shaped stroma. And we see a few nests and groups of cells with occasional glandular lumina. So on the architectural score, I think this would fit as a score 2 architectural grade, and that's a fairly common grade, but it has some glandular differentiation. It's not all solid. It's not all single celled in this situation. Some of the glands are fairly well formed, but most that's only about half or less of those cells. We also look at, of course, the nuclear features, and evaluating this case, we see a mild degree of nuclear pleomorphism. So I think this case would also fall into the grade 2 nucleus category. There's a mild degree of pleomorphism. And then mitotic scoring would be done as well. And this had a low mitotic index. So that gives you a total score of 2 for architecture, 2 for nucleus, and 1 for mitotic score, which sums to 5, which still puts it in the Nottingham grade 1 category. Not surprisingly, this case was ER/PR positive and HER2 negative. So that certainly fits with that scoring. And I will mention here that it's important to correlate the morphology that you're seeing with those hormone and breast marker studies, because what you don't want to do is be scoring something as a mitotic score 1 on H&E histology, and then have the Ki-67 come back at 80%. That would indicate that you're probably not validated in terms of your mitotic counting. But if you've got something in the 8 to 20% range, that would certainly be okay for a mitotic grade 1. All right, well, let's sort of shift gears again. This is a younger patient in her early 40s who has developed a breast mass. And there is a family history in this patient as well. So ultrasound examination showed a very high risk lesion, and these biopsies were obtained. And so this is kind of the other end of the spectrum compared to what we just looked at. Here's solid tumor growth, a lot of sclerosis, really not much in the way of glandular differentiation that we can see anywhere in this tumor. And as we look at the higher magnification view here, we can see an enormous variation in the nuclear size and shape. So this is, I think, a nuclear grade 3. These are high-grade nuclei, wide variation in size and shape, and should be scored as a 3. Architecturally, again, no gland formation, we would score that as a 3. So then looking for mitotic figures, in this situation with all this apoptosis around areas of necrosis, you can almost be sure that this is going to be high grade. And in fact, when we did a Ki-67 score on this, approximately 80% of these tumor cell nuclei were staining positively with the Ki-67 marker. So that fits very well with a score 3 type of tumor. And not surprisingly, these are often the tumors that are triple negative, negative for estrogen receptor, negative for progesterone, and negative for HER2. So certainly a high-risk case underscored by both the histology and the prognostic markers that we routinely employ. So it's always, as I said, it's always good to correlate those findings and fit those together. Now, why is this so dyscohesive? Why did the fragments come out like this? Well, again, that's a feature of the tumor, that there's so much necrosis that it doesn't come out as a clean core biopsy as that previous case did. I mean, you contrast the shape of these samples with these nice sharp cores here. This is a very characteristic scaring carcinoma, whereas this is a very high-grade, poorly differentiated tumor with not as much time, growing so fast that it does not produce the same desmoplastic response that we see in other tumors. Okay, let's move on to another case that came in same day. And this is, I think, a very interesting case because of the differential that it presents. Again, we see a very blue tumor, very sharp boundaries. And looking at this tumor, we see a fair degree of open spaces in these puzzle pieces. But notice one other thing here. Notice the sclerosis in the stroma here is almost basement membrane type of production. So as we looked at this case, yes, it's making some ductal structures, so we'd probably score it as a 2. And the nuclei are fairly uniform, so those might also be scored as a 2. But there's just something about this that looked a little bit funny and different than some of the other tumors. Is this a invasive cribriform carcinoma, or could this be an adenoid cystic type tumor? So adenoid cystic carcinomas of the breast are quite unusual, but because they have a very different response profile, it is important to recognize them at biopsy, if at all possible. So we did do a little bit of additional workup on this case. We did a CD117 and a P63, which were negative entirely, which would be not the case if it were an adenoid cystic tumor. So this case did turn out to be positive with estrogen and progesterone receptor. It had sort of ambiguous score 2 HER2 staining, and so we would reflex in that circumstance to do FISH testing. That's not back yet on this case, but I would not be surprised if it were positive in some degree, because some of these tumors that can be triple positive with these markers as well. And our mitotic index on this case was still fairly low. So this was scored as a grade 2 tumor on the basis of the more solid growth and the nuclear variability and sort of low to intermediate mitotic index. Let's see a few people coming in and out. All right. So let's, if there are any questions to this point, I'll certainly take those. I have one more breast case just to sort of round out our breast sign out for the day. And so here we see a few small cores. And this, I think, underscores the importance of radiographic and pathologic correlation. So typically, when we sign out breast cases, the radiologist who did the exam and did the report or did the biopsy will get a report of what we say or what we see. And so if we would just report a biopsy like this as benign breast tissue, that's not very helpful to him. And it may not be a good service to the patient. On the other hand, if we report that we see a moderate area of stromal fibrosis with benign ductal structures and lobular structures with slight ductectasia, well, then he's able in that circumstance to say, does what the pathologist saw correlate with what I saw? Typically, many of these patients will be reviewed at tumor board, even in the benign circumstances, especially if there's any question of a discrepancy between the radiographic findings and what we've reported. We're not seeing really any degree of hyperplasia here. We're just seeing benign breast tissue with areas of stromal fibrosis. And if that fits with what he saw radiographically, then the patient's fine. But if there's a doubt, then there may be consideration of either rebiopsy at a later point or excision if there's a major discrepancy between their impression and what we've found. Because what we don't want to have happen is to have the false negative biopsy, either because we didn't find it or because he missed it at biopsy. And that's why if they see calcifications, if they see something else that's unique, cystic changes, we need to be evaluating those cases sufficiently that we can close the loop, if you will, in terms of tying together the clinical, radiographic, and pathologic features. This is a great opportunity for radiologists and pathologists to work together along with their surgical colleagues to take good care of these patients. So I can't emphasize the importance of that real-time coordination between your radiographic and pathologic findings. Okay, so we're almost to the top of the hour. Let's go on to another case. And this will change gears completely here. This was a liver transplant. I think I've shown some cases of liver transplant in the past, and perhaps most of you will not see very many liver transplants in your practice. But I think it still illustrates important principles in pathology that are helpful to be aware of. So this liver transplant obviously done for cirrhosis, and that's the history that we received. Patient with end-stage cirrhosis, liver transplant, here's the liver. So there was not an indication of the etiology for the cirrhosis. And I think here at low magnification, you can appreciate that we have some sort of variable macronodules as well as this background micronodular pattern cirrhosis. So let's look here at these micronodular areas first, where most of what we have is just fibrosis. And we see a lot of bile duct proliferation here. And that's what all of these small racemose glandular areas are. And we see these sort of dying or distressed hepatocytes with varying degrees of pleomorphism to the nuclei, loss of surrounding relationships one with another. We're not seeing a lot of fat or lipid here, but we do see a lot of pigment. So pigment in the liver, of course, most commonly is bile. And so as we look at this, it's very easy to think that this is, there's a lot of cholestasis here. And we see some inside the cells, some inside these little ductal structures. But notice that we also see some pigment here in these intervening macrophages. That's a clue that not all the pigment is quite the same. And in fact, even in certain cells, and I apologize that maybe you can't see this particularly well. Maybe I can turn the magnifier on here. Oops. Oh dear. I think that's not what I wanted to do. I thought I had a magnifying glass. Well, you'll be able to come back and look at these. But even in the individual cell, we see this is a bile plug here, but this pigment is a slightly different color. Excuse me. So routinely, of course, we do several stains to evaluate this. And in this particular instance, even at this point, looking at the H&E stain, I was very suspicious that we had both bile stasis and iron deposition. And so I was very eager to look at the iron stain, which I have nicely provided for you here to review. As you see, there's a lot of blue pigment in this liver. This is much more than should be seen normally. This was a 4 or 5 plus amount of iron. And as we see, now you can see in contrast, bile, iron, iron, iron. So this is very helpful to recognize that we have a lot of iron here. Now, patients can get excess storage iron from a variety of circumstances that include hemochromatosis, as well as transfusion and so forth, as possible things that have increased their iron store. So sometimes patients who have acquired hepatitis C through transfusion will also have increased storage iron. But one thing that is very helpful is if you see iron in the biliary epithelium, that is almost the sine qua non marker that says this is hemochromatosis, because transfusion or other sources of iron accumulation do not result in iron being present in the biliary epithelium. And in fact, as we look around on this particular case, there are a number of bile ducts where we can see that iron accumulation. Well, I'm not, here's some more here. Just a little bit, but that's enough. That's enough. Here's more of it here. You can see in that bile duct as well. So that's, I think, very helpful to assign this case the diagnosis of hemochromatosis, which is not uncommon for patients to go many years without a positive diagnosis to explain their findings. And hemochromatosis is notoriously underdiagnosed. Now, the other feature here that I want to call out is that these regenerative nodules have less iron in them than the surrounding parenchyma. And that's because as these nodules grow, they can, they proliferate without the ongoing deposition of iron to the same degree. However, one question that then arises is, are these becoming neoplastic? Are they dysplastic nodules? Are these incipient hepatocellular carcinomas? Because patients with hemochromatosis can also develop that feature. I think one, oh dear, this did not light up really well. There we go. All right, so one of the things that I did to help to highlight this, and it looks as though I have the wrong stain here. Well, so one of the things that, oh, here we go. So one of the things that is useful to understand is the fact that the normal hepatocytes, the normal hepatic parenchyma does not have true endothelial cells, and so will not stain with CD34. However, neoplastic hepatocytes can begin to secrete VEGF, and that can be a marker for either dysplasia or potentially well-differentiated hepatocellular carcinoma. And so I did a CD34 on these nodules, which we see the beginnings of endothelialization within these regenerative nodules. If we go and look over here in the cirrhotic liver here, we do not see any endothelial cells here. Come on, come into focus. Just a few maybe around the portal tracts, but the bulk of this is negative, whereas here in this nodule, we see that many of these sinusoidal cells are acquiring features of endothelial cells. So that would suggest that these nodules are becoming dysplastic. Now, that's not critical in a transplant patient, but it is, I think, important to understand the biology and the process of what's going on here. All right. Well, I've just about run out of voice, and I appreciate you all being with us this morning. I see there is a question in the chat, and let me just see. Oh, thanks, Dr. Tu. I appreciate your compliment. So any questions, we'll be happy to stick around for a minute or two and answer your questions. If not, thank you so much for joining me, and we will hope to see you next month, although I do believe there are some complications on the schedule next month. I may have to adjust the time, but look forward to having you join us again. Please feel free to speak up or type in your questions if you have any questions about the cases today. And as I mentioned, I will post the slides for your review later this morning. Yes, hemochromatosis is iron storage disease. The inability to secrete iron and the continued acquisition of iron lead to an overabundance of iron, which leads to end organ damage in the heart, in the liver, most especially, but also the pancreas and various other organs as well.
Hello, Dr. Hassos.
Hello, Hui.
Hi, I have a question.
Yes.
Very nice case. So in this case, should we perform some mutation analysis to confirm the diagnosis of hemochromatosis? Because this is a hereditary condition, so should we perform any molecular analysis for this?
Yes, that's a very good question. And in many instances, it is useful to do genetic analysis to see that they actually do carry the trait. Not so much for them, because it's not going to make any difference in their treatment, but in order to gauge family risk and things of that sort for other family members, that can be very useful. Usually this is a recessive disorder, but it's a fairly prevalent recessive disorder. And so understanding what the molecular genetic factors are in hemochromatosis can be very useful. It's also important in this situation because this makes the transplanted liver at risk to reaccumulate the disease. And so management of this patient going forward will take into account the need to reduce his iron burden, potentially with chelating agents or other mechanisms to try to reduce his iron burden. Sometimes if patients have polycythemia, for example, or something like that, they actually do bloodletting, the old therapy of taking transfusions off of these patients in an effort to reduce their iron load. So very good question.
Thank you very much.
All right. Well, have a great day, everyone. Good evening, and hope that you'll stay safe, and we will look forward to meeting with you again next time.